interested to have a look and view this uh, conversation, it'll be available for the future viewing as well. And anyone who is interested I'll upload this thing in the YouTube or in any of the social media to have a future look. Okay, coming on to the today's class, and this is like uh, just this is an introduction. This is the first time we are having this kind of conversation in the group, and I would like to continue this thing to happen with anyone who is interested can definitely contribute. I'll really support you guys. And this Zoom version is a paid version, so it's not going to be for 40 minutes, and it's going to be we can extend the discussion and we can extend the conversation even after 40 minutes. And this is purely an educational and academic oriented class. And feel free to have a I would like to get some feedbacks, and also you can uh, give your opinion, and changes which we can do in future can be accepted. Okay, going on to the today's topic, and today's topic is going to be colonic cancer, and we know this is going to be the colorectal part of the uh, colorectal part of the surgical aspect is very important in UK and in Western world. And as a surgeon, plenty of people will come across colonic cancer in Western world and rest of the world as well. Okay, my name is Varun. I'm one of the surgical doctor here in UK, and today's topic I'm going to talk about the surgical anatomy and the pathology, the investigations, the pathology of colonic cancer, the investigations and treatment and different aspects will be dealt in another session. Today I'm going to just deal about the surgical anatomy and the pathology. Okay, the next slide is the surgical anatomy of the colon. The colon is 1.5 centimeter, 1.5 meter in length, and it starts from the ileocecal junction to the rectum. And these are the dimensions and the measurement of each and every part of the large bowel. And it starts from the cecum, ascends as an ascending colon, transverse colon, descending colon, sigma, and rectum. And this is just for the people those who are interested in MRCS, and it's not just for FRCS. This class is going to be shared, and you should be useful for both anyone who's taking MRCS and FRCS. And in this slide, I would like to say about the diameter of the large intestine, and this is the reference is Scandalaki surgical anatomy, and this pictures you can see it in Scandalaki surgical anatomy. The cecum length of the cecum is 5 centimeter, and the ascending and descending colon, they are 10 centimeter, and the transverse colon has got 50 centimeter, and the sigmoid has got 50 centimeter. The first picture you can see the diameter of the cecum and the diameter of each and every part of the large intestine. The cecum is 7.5 centimeter in diameter in an average, and the ascending and descending colon has got 6 centimeter in an average of diameter. Ascending is 6 centimeter and descending is 4 centimeter, and the transverse is 5 centimeter, and the sigmoid is 5 centimeter in the diameter. So these are the normal diameters. And when we look into the X-ray pictures, if it is 1 or 2 centimeters above the normal diameter, we can consider the chances of obstruction. And the next picture, you can see the plenty of cut open picture of the intestine, which shows some hastrations, and the cecum shows ileocecal wall, and just 2 centimeter below the ileocecal wall, the ileocecal wall appears as a slit like opening, and 2 centimeters just below the ileocecal wall we can find the appendicular opening as well. And um, as such, the surgical anatomy of the large bowel. Okay, these are the endoscopic pictures of the large intestine. You can see the hostrations. The first picture shows the endoscopic appearance of the transverse colon, which we can see it's triangular in shape. The lumen is triangular, and these are the folds are the hostrations which we could see in the endoscopy or colonoscopy. Okay, the second picture is the picture of a cecum, which shows the ileocecal valve and the whole of the cecum with. I couldn't see any appendicular opening here. It's actually the cecum with ileocecal wall. Okay, surgical anatomy as such of the large intestine includes ileocecal junction, cecum, ascending colon, hepatic flexure, transverse colon, and splenic flexure, sigmoid colon, rectosigmoid junction, and rectum, anus, and anodome. Here I would like to stress about two things here: the splenic flexure and the rectosigmoid junction. And this is what I'm going to say right now is surgically more important for the people, those who are going to be entering into the surgical field. Per operatively, there are two things which is very important. Rectosigmoid junction is identified by the tinea coli, where the tinea coli spreads all over, continues as a rectum. So the junction between the three tinea coli, which spreads all around the rectum, is the rectosigmoid junction. And the splenic fracture is very important because it was previously thought that it is a drainage area, or it is an area where the anastomosis does not pick up easily. But those old concepts have gone, and this is those old concepts has gone nowadays. And okay, coming on to the ileocecal junction. The ileocecal junction is very important here because in large intestine, especially when we talk about ileocecal junction has got terminal ileum, ileocecal wall, and the cecum. And ileocecal junction includes terminal ileum, ileocecal wall, and the cecum. Terminal ileum is usually, we say it as 10 to 15 centimeters approximately from the ileocecal wall, and the ileocecal wall has got a slit which does not allow any content from the large intestine to enter into the small intestine. And the cecum is a large luminal structure of the large intestine which measures 1.5 centimeter in diameter. Okay, coming on to the next slide. Okay, the terminal ileum, as I said, it's 15 centimeter or terminal ileum, and the importance of the terminal ileum are the three most important things which happens at the terminal ileum. The anastomosis, we have to be very careful with the anastomosis. The attention anastomosis in the terminal ileum can go for leak because the terminal ileum is a fixed part in the small intestine, and it's more there's a high chances of leakage because of its fixed uh, property, and there are chances of anastomotic leaks. And another important thing with the terminal ileum is physiologically it absorbs the conjugated bilirubin and the B12. So when the patient has when the patient is devoid of terminal ileum, there's a chance of vitamin B12 deficiency, and also there's a chance of biliary stone formation because of um, malabsorption of the conjugated bilirubin. And this is the picture which shows the ileocecal valve and the positions of the appendix. And coming on to the blood supply of the large intestine, starting from the cecum is supplied by the cecal artery, which has got two branches. Sorry, which has got two branches. One is the anterior cecal artery and the posterior cecal artery. The anterior cecal artery rests on the superior fold of the mesentery, and there is a posterior cecal artery branches which gives branches to the appendix called as appendicular artery. The right side of the colon or the ascending colon is supplied by the right colic artery, the middle colic artery supplies the transverse, and the left colic artery supplies the descending sigmoidal artery. And the right colic and the middle colic are the branches from the superior mesenteric artery. The left colic and the sigmoidal artery are the branches of inferior mesenteric artery, and the rectum superior rectal artery is also from the inferior mesenteric artery. So here in this picture, I would like to stress the lymph nodes of the colon, which is very important for the colonic malignancies. The lymph nodes of the colon are classified into three stages: epicolic nodes, which are around the colon, and the paracolic nodes, which are around the small blood vessels supplying the colon, and there are intermediate mesocolic nodes which are around the major blood vessels, and the other nodes or the lumbar nodes which are around the root of the main vessels. So these are the nodes which we are very much worried about during the surgeries and uh, during the assessment process of the colonic cancer. Okay, coming on to the posterior relationship of the cecum or the large intestine. So everyone knows that the cecum is partially intraperitoneal and partially retroperitoneal, and the ascending colon and this descending colon are the retroperitoneal structures, and the transverse colon and the sigmoid colon is intraperitoneal. So when we do a dissection, when we try to reflect the colons, the posterior structures which we could see are the psoas muscles, nerves such as lateral femoral cutaneous, lateral cutaneal femoral, it's femoral branch of, sorry, there's a mistake here, lateral femoral cutaneous now and genitofemoral now, and there are gonadal arteries and veins, and the most important structure which is posterior to the colon, both on the right and the left, is the ureter, right ureter and the left ureter. In a while I'll show the picture which shows the relationship between the gonadal vessels and the ureter. Okay, here in this picture we could see the um, large intestine and the transverse colon, which is taken off, which shows the posterior relationship of the transverse colon, which is which is at the level of L1, and and the posterior relationship of the ascending and the descending colon. Coming on to this slide, this is laparoscopic anatomy of the colon. So this will give advanced approach to people those who are interested in colorectal surgeries. So in the first picture, we could see the ascending colon and the descending colon, which is attached to the fusion fascia of Told. I think plenty of you will be knowing about the line of Told, which is the avascular plane or avascular line through which we can dissect out the large intestine and the large intestine, especially the ascending colon and the descending colon. So when we take up the line, when we make an incision on the line of Told, we go into an avascular plane, which is called as fusion fascia of Told, which reflects whole of the ascending and the descending colon, and takes off the whole of the mesentery with the ascending and the descending colon. And posterior to the fusion fascia of Told, or fusion fascia of Told, is the right kidney or the left kidney, and with the ureter. And in the second picture, in the picture B, we could see the two structures, very important structures. When we reflect the colon with the mesentery, we could see laterally usually we go from lateral to medial dissection in any of the colonic cancers. So the lateral most structure which we can come across is the gonadal vessels, and the medial most structure which we come across is the right ureter. So everyone know how to check the ureter and the vessels, and the dissection goes in this way. And this is the picture which shows about the retroperitoneal property of the ascending colon and the descending colon. And in the first picture we could see the cecum which is slightly free, and that's the reason. If there is a free cecum which has got which is not partially attached to the uh, retroperitoneal structure, can cause cecal valvulus. And the second picture shows, as I said you, the anterior cecal artery, which goes in the anterior fold of the mesentery, which covers the small intestine or the ileocecal junction. This is called a superior ileocecal fold or fossa, and there is something called as inferior ileocecal fold or fossa. These are the references from the Scandalake surgical anatomy. And coming on to the next picture, and this is another picture which shows about the dissection of the large intestine, how it goes around. And these are the three tinea which are in the picture. In this picture C, we could see the three tinea in the large intestine, and how the mesentery is dissected in the laparoscopic procedure or the open procedure. So just go lateral, dissect out, take off the peritoneum, and the only two important structure which we will come across is the uh, uh, gonadal vessels and the ureter, and posterior to it is the psoas muscle with the nerves over the psoas muscle, and slightly cephalically there could be gyrota fascia with the kidney. And coming on to this next picture, so this is the laparoscopic picture of the left, where left sorry, this is actually the left colon, and I could see only the right, the pictures from the right. So these are the laparoscopic picture which shows the right ureter. So the ideally in this, at the initial stages of the surgery, we dissect out the, we push out the uh, small intestine out of the pelvis and check for the promontory, sacropromontory, and then we check for the ureter and the iliac vessels. See, these are the most important guides for the laparoscopic colonic resections. Okay, coming on to the next slide, and this is regarding the anterior resection or the low anterior, high anterior resection. In any of the anterior resection, the first thing which we trace is the superior rectal artery. And this, instead of this picture, I'll show this picture. So when we see into the pelvis, the thing, the mesentery is dissected. The mesentery in the sigmoid mesentery is dissected out. The first structure, first vessel which we come across is the superior rectal artery. So this, we could see the medial structure which is superior rectal artery. Once we dissect the superior rectal artery, we go posteriorly to check for the ureter. So the lateral structure is the ureter. So once we preserve the ureter and the superior rectal artery, the anastomosis can be taken up by the superior. Sometimes there is a chance of that, sometimes we take off the superior rectal artery if it is low anterior resection. And this is a useful slide which we can take into mind to think about the superior rectal artery and the relationship of the ureter, which can help the surgeons to do a perfect dissection. And coming on to this next, okay, coming on to the colonic cancer as such. And this colonic cancer, the colonic cancer in UK, this is going to be, most of the things are from the companion series. And I'm not sure about the name of the book, it's a gastro book. And this these are the references, which all these things are from the books and the internet, and from the references. If anyone needs any reference, I'll give you the references at the end. Okay, colonic cancer. There are 16,000 deaths which has been recorded in 2014 in UK, and there are 41,000 new cases which is happening each and every year. And most of the cases are the colonic cancers, and 15,000 are rectal, 26,000 are colonic. Overall, the 5-year survival rate of any colonic malignancy, including the rectum and the colon in UK, is 57%. And as okay, how to differentiate whether it is a rectal cancer or the colonic cancer? So as per the uk definition, the rectal cancer is defined as a tumor within 15 centimeter of the anal verge. I think this will be helpful for any people those who are doing endoscopy or sigmoidoscopy. So any cancers within 15 centimeter of the from the anal verge during a rigid sigmoidoscopy or flexible sigmoidoscopy are considered as rectal cancer in UK. However, in USA, they prefer it for 11 or 12 centimeter. So why is this important? This is important because there is the radiotherapy acts the radiotherapy is very important in differentiating the treatment aspect of colonic cancer and the rectal cancer. So this plays a vital role uh, in knowing whether it is a rectal cancer or the colonic cancer. Okay, then coming on to the frequency of anatomical locations of colorectal cancers. Frequency. Okay, so in this picture we could see the majority of the colonic cancers are the left sided in UK. So you can see 37% of the colorectal cancers are from the rectum and 27% in the sigmoid and 5% in the descending colon. So almost 60% of the colorectal cancers are usually in the left-sided colon, and rest are from the right side in the transverse colon. Could see here 20%, just 20%, around 20% of the colorectal cancers are from the right from the right side of the colon. Okay, so coming on to the etiology, everyone knows that plenty of etiologies, and it's a very common thing, which it's easily everyone will be knowing what's the reason, what is the etiology of colonic cancer. So coming on to the stratification, how we stratify the etiology. So there are increased risk. These are the increased risks of colonic malignancy, and this has got probable or convincing evidences. So alcohol intake of alcohol at least 30 grams per day is has got increased risk, and body fatness, meat preserved by smoking, currying, salting, and additional, especially preserved meats, and increased BMI, weight circumference, and weight hip ratio, developmental factors leading on to linear growth areas like adult attained height. So quickly attaining the adult height at an earlier age, and processed meat and red meat consumption. These are the increased risk of colorectal cancers. And coming on to the next, okay, with limited or suggestive evidences, these are the causes of these are the causes of colonic malignancies, but these has got limited evidences, like cigarette smoking, environmental carcinogens of mutagens, food containing heme and heterocyclic amines from fried meat and fish, and low intake of fruits, and low intake of non-starchy vegetables, and microbial dysbiosis are nothing but different microbial um, in the colon. So these are the etiology which has got very decreased risk, or these are the evidences which says there's a prevention, or there is an uh, uh, increased there's a chance of, what I can say, um, these prevents the probably prevents are helpful for decreased prevalence of colonic cancers. For example, the NSAIDs, the chronic intake of NSAIDs causes decrease it's not causes, it decreases the incidence of colonic cancer. Calcium and vitamin D supplements decreases the chances of colonic cancer. Food containing high fiber diet and hormone replacement therapy and lean body mass, increased physical activity, evidence, uh, and whole grains, all these causes some 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 kind of benefits for the colonic cancer. The people, those who are with these habits or with these things, are less prone for chronic malignancies. I'll let you know what's the reason behind this. We'll discuss in detail. Okay, these are the reasons why the colonic malignancies are common because of these etiology. For example, for example, okay, dietary fat. What happens with dietary fat if we take increased amount of fat, and why they are prone for red meat, especially the red meat or the processed meat. So when we take a processed meat or red meat, there's increased enhancement. There's enhanced hepatic cholesterol and bile acid synthesis. Especially the secondary bile acids are the culprit for the colonic malignancies. And there's a high amount of corn oil or beef fat increases the colonic ornithine decarboxylase level, which rapidly proliferates the intestinal mucosa, especially the colonic mucosa, which causes a trigger for the colonic malignancy. And there's an activation of protein kinase C by the bile acids in colonic mucosa. So all these activations causes hyperplasia of the colonic mucosa, which can lead on to the colonic malignancy. There's a there's an evidence, some evidence from the research saying that these are bacteria which can cause colonic malignancy, and Fusobacterium nucleatum, which is found highly in the colorectal tissue, colorectal carcinoma tissues in the mouse models, probably could cause colonic cancer. And there are a few other uh, bacteria which could cause colonic malignancy as Streptococcus galacticus and Clostridium septicum and H. pylori. And these are, and there is no proven evidences for all these things. These are the query causes, and there's no proven evidences. And how come the how come the vegetables and fruits and that causes decreased uh, helps in the prevention of colorectal cancers? So the diets rich in vegetables, fruits, and whole grains causes decrease in colorectal cancer's risk, and increased fiber intake in the form of whole wheat or rye reduces the concentration of fecal secondary bile acids. So the main culprit here in colonic cancers are the secondary bile acids or fecal secondary bile acids, which irritates the colonic mucosa to form to, to cause hyperplasia. And coming on to the few other things like vitamin A and vitamin C acts as an antioxidants, which helps in any kind of malignancies. And there is a proven evidence saying that with supplemental calcium and vitamin D alters pre-neoplastic features of colorectal adenomas. Uh, I would like to state something here in this at this moment. I'll do a separate session for polyps and the uh, uh, endoscopy and the polyps, which leads to the colonic malignancy in a separate session. Okay, back to the slide. And 40 to 50% reduction of colorectal carcinoma related mortality in patients, in persons uh, who take aspirin and NSAIDs. And there are few studies which shows that we can take NSAIDs for prevention of colonic malignancies. There are good evidences to say that the NSAIDs prevents colonic malignancies, and lower doses of aspirin were more effective than the higher doses of aspirin in prevention of colorectal carcinoma. And the expression of COX-2 is helpful in the sense that it prevents expression of COX-2, and the aspirin or the COX-2 inhibitors helps in the prevention of colorectal carcinoma, because the COX-2 is expressed in 80 to 90% of colorectal cancers, which again, when we prescribe or when the patient gets a long-term aspirin, they have less incidence of colorectal cancers. Okay, coming on to how NSAIDs protects or helps in the decreased risk of colorectal cancers. Or NSAIDs inhibits the activation of genes by PPAR receptors, PPAR receptors, and thereby decreases the incidence or risk of colorectal cancer. Use of magnifying endoscopy, this is another thing which is very important. This will I'll deal this thing again in another session, called as aberrant crypt foci. These are the aberrant crypt foci. The aberrant crypt foci give gives an image, or gives an early warning signs of any malignancies in the polyps. And there is another statement saying that estrogen protects colonic cancer by decreasing production of secondary bile acids. So those who are on hormone replacement therapy, they have less chances of colorectal cancers. So regarding the genetics of the colonic cancers, there are two forms of colonic cancer: sporadic colorectal carcinoma and the uh, colorectal carcinoma, uh, and the genetic causes of the colorectal carcinomas. The sporadic form of the colorectal carcinoma, uh, sporadic form of carcinoma is a somatic genetic disease influenced by the local colonic environment or an individual's genetic background. For example, this can happen in any patient, those who are prone for environmental risk, and also for those who are prone for environmental risk, and it can happen even without any prior family history of colorectal malignancies. So this is again another series of things which I'll deal again with the polyp. There's a named evolution of disease process in the colon cancer. For example, if there is a normal colon cells or the normal mucus of the colon, it gets methylated. Then when there's a methylation abnormality of these cells, it goes for there is a technical issue. I don't know what happened. Okay, back to slides. And okay, back to slides. Okay, this is how the sequence of events which happens when there is a colonic malignancy. The normal colon mucosa gets, when there is a methylation abnormality, it goes for hyperproliferative epithelium, or there is a chance of epithelial hyperplasia. And when there is a epithelial hyperplasia, there is inactivation of any kind of inactivation of APC or the MSH genes, which leads on to adenoma. When there is an adenoma with KRAS mutation or any of the tumor suppressor gene mutation, which leads on to the colonic malignancy or the adenocarcinoma of the colon. Okay, so these are the endoscopic appearance of the aberrant crypt foci, and the corresponding the um, genetic aspects, or the gene mutation which happens in the uh, colon cancer pathology. I don't want to get into this thing in depth. Okay, here I would like to summarize this thing here. There are two proto-oncogenes, first in the list and the last in the list, which is more prone for colonic malignancy, which is KRAS, which is very important, and the tumor frequency is 50%, and the BRAF, which is 5 to 10%. There are few tumor suppressor genes which can cause the chronic malignancies. Again, it's the APC gene, adenomatous polyposis coli gene, APC, and the TP53 or P53 tumor suppressor genes, which are more common colonic, which are more common tumor suppressor genes, which can cause the colon cancer. Coming on next is the DNA mismatch gene or micro MSI genes, micro MSI genes. I'm not able to micro instability gene, instability gene mismatch, DNA mismatch repair. So these are the most three important genetic deformities which can lead on to colonic malignancy. Okay, so these are the familial colorectal carcinoma. When coming on to familial colorectal carcinoma, we can't leave the APC gene or the familial adenomatous polyposis gene. Polyposis. There is a 100% risk of colonic malignancy when you have a FAP gene, when you have FAP, and which is caused by APC gene. And how to differentiate with an FAP from FAP to the Lynch syndrome or non-hereditary HNPCC, which is okay. In FAP, we have hundreds of polyps when we do a colonoscopy, and if it is when it is Lynch syndrome, uh, hereditary non-polyposis colorectal carcinoma syndrome, when in this the number of polyps are less, and they are flat. There are flat polyps, and the transition in the Lynch syndrome, the transition from adenoma to carcinoma is a shorter time. And these are the few classic features of Lynch syndrome. I'll go in depth about the Lynch syndrome in the next few slides. And the other syndromes which can which comes under familial colorectal carcinoma are juvenile polyposis, Posterior syndrome, and I will talk about the polyps and the different types of polyps and different syndromes in another session. Okay, coming on to the how. Okay, coming to the Lynch syndrome, it's very important, and there are plenty of things going around Lynch syndrome. So this is a revised guidelines and revised Bethesda guidelines to diagnose Lynch syndrome, and the these are the criterias to comes under the guidelines. The colorectal carcinoma, the people those who are diagnosed with colorectal carcinoma in less than 50 years of age, and there is a presence of synchronous or metachronous colorectal carcinomas or other Lynch syndrome associated extracolonic malignancies like ovarian, stomach, ureteric, renal pelvis, or other extracolonic malignancies. And if the patient presents with any extracolonic malignancies, the syndrome is called as Tory variant of Lynch syndrome, can pronounce it in any way. And the colorectal carcinoma with MSI-H phenotype is diagnosed in any individual who are less than 60 years of age. Persons with colorectal carcinoma and a first degree relative with Lynch syndrome related tumor with one of the cancers diagnosed less than 50 years of age. So any people, those who have less than 50 years of age and those who are diagnosed with colorectal carcinoma, we have to think about the Lynch syndrome. And the most important thing why we have to think about Lynch syndrome is it is autosomal dominant. Definitely the person, there is an inheritance of this Lynch syndrome to the future generation in the family. And the person with colorectal cancer with two or more first degree or second degree relatives, the Lynch syndrome related tumors regardless of age. So the criteria depends on this is a revised criteria. I'm not sure which criteria. I think still we in UK we follow the Amsterdam criteria. I'll I'll say about the Amsterdam criteria in the next few slides. Okay, coming on to the risk of developing colorectal cancers. How what are the risks of developing colorectal cancers? Any individual, this is an average risk of colorectal carcinoma, any individual who are increased more than 50 years of age with, these are the criteria with average risk, they don't have a high risk of getting cancer. Any patient who has got 50 years of age and with no family history of colorectal carcinoma, no adenomas, and no history of inflammatory bowel disease, and there's increased risk of colorectal carcinoma in patients those who have personal history of colorectal malignancies in the family and personal history of adenoma or anything in the family. The risk of developing adenomas is very high, especially especially the FAP, and a family history of sporadic colorectal carcinoma again have increased the risk of colorectal carcinoma. Patients those who have inflammatory bowel disease, either it's more common in ulcerative colitis, in inflammatory bowel disease, there's a 3% chance of colonic malignancy, especially mucinous type of colonic malignancy. And coming on to the next slide, and the high risk, any patient those who have syndromes associated with colorectal carcinoma, they have high risk of colonic malignancy in that, especially all these syndromes, blood sugars, FAP, attenuated FAP, Moyer-Torre syndrome, any patient those who have all these things. And in this slide, I would like to say about family colon cancer syndrome X. What is family colon cancer syndrome X? So it's defined as an individual with colorectal carcinoma whose family meets Amsterdam criteria 1, but but whose tumors are DNA mismatch repair proficient and who does not have an increased risk of extracolonic cancers. In other words, any colorectal carcinoma with some DNA mismatch or microinstability, DNA mismatch or microinstability without an extracolonic cancer comes under this criteria. So how to remember the Amsterdam criteria easily? It's 3-2-1 rule. 3 affected members, 2 generations, and 1 under 50. Can be either 1 or more under 50, but this is how we remember the Amsterdam criteria. 3 members, affected members, minimum of 2 generation, and 1 under 50. And most important thing is in this criteria, the FAP, the familial adenomatous polyposis has to be excluded. Coming on to this, I think I dealt about this revised Bethesda criteria, and okay, these are the gross pathology of any cancer, any colonic cancer, and mostly the right-sided cancers are huge ulceroproliferative cancers, and the left-sided cancers are ulcerative and stricture type. This is the common variety, but this can happen here and there. But the commonest thing is right-sided cancers are ulceroproliferative with some pedunculated, which you could see in this first picture, where there is ulceroproliferative lesions. In the left-sided cancers, it is usually a stricturous and annular type. And when it comes to flat type, how the UK guidelines says what is the flat type? The flat type, the third picture shows the flat type of the malignancy, the ulcerative type of malignancy. The flat type is nothing but the depth of the dysplastic tissue is not more than the twice that of the mucosa. Okay, I think there's some problem with the connection, probably. Coming on to the slideshow again. Okay, when it comes to the flat are the flat malignancies, the depth of the dysplastic tissue is not more than the twice the depth of the that of the mucosa. That's how the flat malignancies are said. Okay, the most important, the most common type of malignancy everyone knows is the adenocarcinoma of the colonic cancer or the adenocarcinoma. Even there can be 5% chances of non-adenomatous carcinoma in colon, and they are classified from less differentiated to the poor, sorry, highly very well differentiated to the poorly differentiated. Can be either well differentiated, moderately differentiated, or poorly differentiated. And most of the colonic adenocarcinomas, they have mucus in the colonic tumors, and which can be stained by periodic acid shift. And when it comes to poorly differentiated colonic malignancies, the mucin is less prominent in the poorly differentiated colonic cancers. The mucinous are the colloid cancers are most common in patients with Lynch syndrome or ulcerative colitis or early age, which has got a very good prognosis. And other, as I said, there are less chances, 5%, less than 5%. There's a chance of non-adenomatous carcinomas as well. Okay, how the disease progress? Most of the colorectal cancers grow at a varying stage, and there's a lot that can be long period of silent growth. There can be long period of silent growth, and it has been said, and this even I was surprised to see this thing. There is a 17 There can be 17 years for a large benign tumor to evolve into a advanced cancer. These are the evidences from the I've quoted the evidence here. When I was surprised to see this, it can be 17 years for a benign tumor in the colon to become an advanced cancer. However, the most important thing is, once if it gets malignancy, it just takes 2 years for the malignant cells to get malignant cells to metastasis. So in other words, a benign tumor can become a malignant and advanced cancer in 17 years, but a malignant cancer will metastasis in just 2 years. So, okay, in terms of anatomy, the colonic cancers are less riskier compared to the rectal cancer. There are two things, most important thing. One is rectal is devoid of serosa, and there is a chance of increased, there is the cancers gets advanced locally. And the other thing is the rectal has got two blood supplies. One is portal blood supply, and the second one is the one is portal blood supply, and the second one is the systemic supply. In other words, the superior rectal artery is from the portal system, and the middle and the inferior rectal artery gets into the systemic circulation. So these are the reasons. um, Seems to be like rectum has got on the lesser side of poor prognosis. Okay, how the spread happens, and most of the colonic cancers, it spreads from the lumen, and from the lumen to the lymph nodes, and to the central lymph nodes, and then to the liver and then to liver. So the extension of the primary tumor intramurally and parallel to the long axis of the bowel most often is limited. I mean, the external proximally and distally. The lymphatic and the hematogenous spread is unusual before penetration of muscularis mucosa. So any tumor which is T1 has got less chances of lymphatic or hematogenous spread. However, as I said, rectum is relatively immobile, and lack of serosal coverings causes spreads contiguously. The rectal has got dual blood supply, so there's a chance of metastasis to liver a bit earlier, and even the even to lung, as it has got dual blood supply and has got systemic spread. And this is very important, which I wanted to mention here, is there is a chance of vertebral metastasis of colonic cancer because of the spread via portal or vertebral communications through bats and vertebral venous plexus. So there is a communication between the portal vein and the vertebral veins through the bats and plexus. Probably could be the reason for the lumbar and thoracic vertebral metastasis. Coming on to the staging of the tumor, the staging goes. There are two types of staging in colorectal cancers: Duke staging and the TNM staging. Though TNM staging is followed everywhere, Duke staging is still followed in UK, and the A is limited to the tumor, wall of the colon, and B just goes out of the uh, colonic wall, and C1 is with pericolic nodes and C2 with distant nodes. The Duke staging and TNM staging again goes in the same way, just to the mucosa, muscularis mucosa. I think everyone knows about. We are not going to go in depth about the T1 and 2 everything. In nutshell, stage 1 has got T1 or T2 with no nodal metastasis is stage 1, and T3 and T4 with no nodal metastasis is stage 2. Any T with nodal metastasis is stage 3. Any T and any node with liver metastasis is stage 4. And this is more than sufficient in staging, clinical staging as a surgeon. And what are the how prognosis are classified? Any well differentiated tumor with microsatellite instability and diagnosis in an asymptomatic patient, rectal bleeding as presenting symptom, better the prognosis is good for colonic than the rectal tumors, and it's better for left colonic tumors than the right colonic tumors. Complete eradication of tumor after preoperative therapy like neoadjuvant therapy has got a very good prognosis, and polypoidal or exophyte tumor have a better prognosis than the ulcerating or the strictures or infiltrating lesions. So, what are the diminished prognosis? Any tumors with many tumors was any poorly differentiated tumor with lymph node metastasis or distant metastasis with perineal invasion, and those who are like syndromic or genetic with some mutations has got poor prognosis. Regarding the duration of symptoms and tumor size, duration of symptoms and tumor size doesn't have any effects on the prognosis. How big is the tumor is not going to influence the prognosis of the patient or prognosis of the disease. Okay, coming on to the relative survival of any colonic malignancies, rectal malignancies, which we could see here. The rectal malignancies got bit less prognosis, and the colonic malignancies got very good prognosis. And when the there's it depends upon the stages again. When in stage 1 it has got very good prognosis overall. If the 5-year survival rate is very low with in the stage 4, and these are the uh, graphs which shows how how the disease progress and what are the prognosis in different stages of the colonic cancers. Coming on to the symptoms of the colonic cancers, everyone will must be familiar with with the symptoms. In terms of the UK guidelines, I'll throw some lights on the symptoms and how it is dealt in UK. Okay, and in general, any anemia which has not been diagnosed, which doesn't have any reason, has to be investigated for colonic malignancies at all ages. And any anemia can cause fatigue, shortness of breath, and angina. And any anemia has to be investigated for malignancy. Right-sided colon cancers causes a mahogany-colored feces blood mixed with stools, and there can be abdominal discomfort as a main symptom. That could be vague mass in the right or left ileal fossa or any of the colon occupying anatomical area. Cecal tumor can cause a block in the ileocecal wall, causing small bowel obstruction, and there can be tumor left tumor which can cause large bowel obstruction. The left tumors has got two most important thing which causes the symptoms of left tumor. One is large bowel obstruction, and the second one is the altered bowel habits, which should be persisting for 6 weeks. So that's the criteria which the NICE says. Any altered bowel habits which is persistent for 6 weeks has got important role, and anything which is less than 6 weeks should be investigated, but the 6-week criteria is very important. And rarely what happens with sigmoid cancers, it can fistulate into the bladder, it can fistulate into the stomach, it can fistulate into the intestine causing gastrocolic fistula, or fistulation into the bladder causing nematuria or feces in the urine. Okay, and this picture is from the companion series. Um, these are the symptoms with high risk. The high risk symptoms. What are the high risk symptoms for a colorectal cancer? Rectal bleeding with a change in bowel habit to rose stools or increased frequency of defecation persisting for 6 weeks in all ages. That's very important. In all ages, any patient who has got altered bowel habits with bleeding for 6 weeks at all ages is at high risk. And any patients who has got change in bowel habits without rectal bleeding, but the age is greater than 60, is again high risk. Persistent rectal bleeding without anal symptoms, and soreness, discomfort, itching, lumps or prolapse of pain in the back passage, again at more than 60 years of age, again are at high risk of colonic malignancy symptomatically. There's a palpable right-sided mass, a palpable rectal mass, unexplained iron deficiency anemia, or any kind of anemia at all ages to be are at high risk of colorectal cancers. So, what are the low risk for colorectal cancers? And patients with no iron deficiency anemia, no palpable rectal or abdominal masses, rectal bleeding with anal symptoms. For example, if there's a patient who has got obvious young patient with obvious hemorrhoids, with rectal bleeding, with no persistent change in bowel habits at all ages, there's a low risk of colorectal malignancies. And for example, any patient who's got anal fissure with rectal bleeding, and there's a less chance of um, colorectal malignancies. Without any change in bowel habit without rectal bleeding, again less chances. Transient change in bowel habits less than 6 weeks, less chances of colorectal malignancies. Abdominal pain as a single symptom without signs and symptoms of intestinal obstruction, again less chances of low risk of colorectal malignancies. So, what are the differential diagnoses of any colonic cancers? When there is a mass lesion, it's not always a colorectal cancer. We have to think about even the non-colorectal causes of mass lesions. Example, like benign tumors and diverticulitis, infection, tuberculosis, which is highly unlikely in UK, and inflammatory bowel disease, ischemic colitis, and solitary rectal ulcers are the mass lesions which are the differential diagnosis for the colorectal cancers. And other differential diagnoses like diverticulitis, inflammatory bowel disease, IBS, medications also should be considered. And when there is a rectal bleeding, what are the other causes of rectal bleeding apart from colorectal malignancies? Are diverticulosis, hemorrhoids, inflammatory bowel disease, infective colitis, ischemic colitis, and solitary rectal ulcer. I'll deal these things in a separate session. Okay, investigation and treatment, and definitely in a separate session. This is just surgical anatomy and pathology and few symptoms. That's it. And I'm just going, thank you all for listening to me, and I'll stop sharing things. Let's go for discussion. I'll unmute all, and anyone who is interested for discussion can. Thanks, Mariam, for coming and participating.
Yeah, I would like to ask a question.
Sorry, I don't hear you. Hello.
Yeah.
I could see someone. Thanks for very useful. Thank you.
Hi, Varun.
I I could see few people here, and Mariam can. I'm unmuting Mariam. Muting.
Hello, I am Dr. Nasser. I want to some question.
Yes, Nasir. Yes, you can speak now. Yeah,
Okay, thank you. Sir,
come.
can you explain the what is D1, D2, and
Sorry, I'm
resection?
not. Can you please bit audible?
Hello, can you
Yes.
hear me?
Yeah.
Can you explain the D1, D2, and D3 resection in colon cancer?
No, that's what I'm saying. This is. I'm not. I'll do a separate session on the investigation and treatment in detail again in another session, and this is just an introduction to colorectal cancers. And definitely I'll do another session
Okay,
regarding the treatment part. I have not talk, I didn't speak anything about the treatment part. I'll do another session about the treatment part.
okay. Sir, I have a suggestion. When you plan for next lecture on treatment, please emphasis on the lower rectal surgery, where to do low anterior resection, where to do ultra low resections, and where to do APR.
Sure, sure, definitely. I'll do it for sure.
Hello,
Not able to.
hello. Can you hear
Hello.
me?
Yeah, yes.
Hello. Yes, sir. I have a suggestion. When you talk in next session about the treatment plan, please emphasis on the low anterior section, ultra low anterior section, and pull through operation and APR. What is the criteria and what is the length of the cut where we should do the enhancement?
Sure, sure, sure. We'll do it. Definitely, I'll do it. And that's not going to be the today's topic actually. Definitely, I'll do it on some other day.
Okay. I am waiting. Because some examiner ask about the what is lower anterior section and what is the ultra lower anterior section and what is the and when you do pull through operation and how much length from the inner verge is required. These are the most common question asked in the exam.
Okay, okay, okay. Any other questions or any other discussions from?
Yeah, Mr. Varun.
Yes, please.
Yeah, I'm Dr. Asif. I'm a colorectal surgeon.
Yes, sir.
So I'll just, for the information of others,
Mm-hmm.
you said about the progression of adenoma to a carcinoma.
Mm-hmm.
So you mentioned 17 years.
Yeah, actually,
So
that's what even I said the
yeah.
said in the even I was surprised to hear about the. It's actually the benign tumor to become a malignancy, and I went through the literature after that, and I felt it was a obvious. Okay, yes, go ahead with the questions. Let me hear to your question first.
So it's not a question. It's just to clarify
Mm-hmm.
that the adenoma carcinoma sequence,
Mm-hmm.
if a question is asked the about the time period,
Mm-hmm.
so it should be 8 to 10 years. It's not 17 years.
That,
So most of the
okay.
literature which
Mm-hmm.
favors,
Mm-hmm.
which discusses about the adenoma carcinoma sequence is
Okay.
on an average 8 to 10 years. So 17
Okay.
years, it may be in some patients, it can be there. In
Yeah.
some patients, it may be even early. But on
Okay.
an average, it's
Okay.
always 8 to 10 years.
Okay. 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 Because even like 17 years, when I saw this thing 17 years, I just wanted to quote the reference when there is some controversial thing. Even I went through the literature. Seems to be okay. I'll try to get a clarified
There
thing
may be
like
single paper. It's a single paper. It's a single.
yeah.
Yeah, it's a single paper, but
Mm-hmm.
if you look at the international consensus guidelines,
Mm-hmm.
like the American and even the English guidelines
Mm-hmm.
and the textbooks, the good textbooks, they all mention 8 to 10 years.
Okay, okay,
So
okay.
17 years, I have not. I'm practicing colorectal research from last 5 years.
Mm-hmm.
So I've never seen anywhere that 17 adenoma takes 17 years to become a carcinoma.
Okay, okay, okay. Taken, sir. Great.
Then second thing, you said about the conditions where if there's a bleeding, rectal bleeding,
Mm-hmm.
and there's an obvious anal cause, say a fissure is there or hemorrhoids are there.
Mm-hmm.
So that's a low risk.
Mm-hmm.
I am not sure about the literature, but there are guidelines where
Mm-hmm.
it's clearly mentioned that if a patient has hemorrhoids
Mm-hmm.
and he is above 50 years of age,
Mm-hmm.
you should always do a rigid sigmoidoscopy or a flexible sigmoidoscopy if it is available to you.
Yeah, yes,
And in
I
my practice,
agree with you.
also,
Mm-hmm.
we have seen that lots and not lots, but many patients
Okay.
present to us with hemorrhoidectomy. They have been operated previously for hemorrhoids,
Mm-hmm.
and 2 years, 3 years later, they come to us with a rectal or a sigmoid cancer, upper rectal or a sigmoid cancer.
Okay, okay.
So
No,
we should
here,
not take
no,
any rectal bleeding with obvious hemorrhoids, with obvious anal pathology,
no, no. That
and
one actually.
high risk
Sorry to stop you
otherwise.
here, sir. Sorry to stop you here. Actually,
Yes, sir.
it's rectal bleeding with anal symptoms and no persistent change in bowel habits is a low risk. And they didn't say that there won't be any chances. They say that there's a low risk. But this I think I took this thing from the companion series, and what they say in the high risk is any hemorrhoids is definitely high risk. So any change, like for example, rectal bleeding with some lumps in the back passage, like soreness, discomfort, itching, lumps and prolapses or pains, definitely are at high risk. So that's what I mentioned, like soreness, discomfort, itching, lumps, prolapse or pain greater than 50 years are at high risk. And patients who have rectal bleeding without altered bowel habits, are less risk. And that doesn't mean that actually we don't have risk. Still there's a chance of malignancy. You're right, actually.
Okay. Thanks. And one more, just a suggestion again.
Hmm.
In your initial slides, you showed the chances of injury to the right ureter once you are doing the laparoscopic rectal resections. So it's more
uh,
common is the left one.
no,
Right?
no,
Yes, it
no,
may be, it may happen, but
okay, okay, okay.
you
No,
pointed
actually, I
to right. You
mentioned
pointed
that
to right
there's a
side.
medial, the ureter can be found medially, and I didn't mention
Ureter is
anything
always
about,
medial
yeah,
to gonadal vessels.
yeah, gonadal vessels are lateral, and the ureter is always
Yeah,
medial. And I didn't mention anything about
medial. Yeah.
ureteral injury. I think ureteric injury can happen most commonly, as you're right. Left-sided left hemicolectomy or left side dissection can cause increased risk of ureteric injury because of the uh, close proximity to the blood vessels and this sort of thing. Agreed, sir. Okay,
Anyways, nice presentation to begin with. I really
yeah.
appreciate your efforts.
Thank
It
you.
was a great thing. Congratulations.
Thank you. Anyone else? Anything? Can we stop, or can I stop the recording, or shall we end this session? Okay. Thanks for attending. I'm going to stop. I'm going to end the session. Thanks for attending, and I wish anyone can contribute. I'm happy to help you out with the um, session, and anyone can become a host and contribute with some sessions. Thanks for attending. Stopping it. Thank you.